Welcome to the Learnskin podcast with Dr. Raja and Dr. Hadar, where they discuss all things skin. Skin is fascinating because it affects us in so many ways, like our health, psychology, and how we connect with those around us. This podcast delves into the art and science of skincare. A short disclaimer before we get to the good stuff. Dr. Raja Sivamani and Dr. Hadar Levtov are board-certified dermatologists. This podcast is meant for educational and informational purposes only. All opinions shared do not express the views of Learnskin. Neither this podcast nor any information contained within it are a substitute for professional care by a doctor or other qualified medical professional. This podcast does not constitute medical or other professional advice or services.
Hey Raja, how are things going today?
Hey Hadar, pretty good. I think we have a pretty good podcast today.
Oh yes, this is a very interesting topic, a topic that's not actually talked a lot about, but I bet you people will be interested. And I know this because we see this all the time in clinic, and it's a very relevant topic. So go for it.
Yeah, and before we jump into the topic itself, let me introduce Dr. Jennifer Soung. She is a board-certified dermatologist, a very good friend of ours, and she also was the chair for the Psoriasis Continuing Medical Education series on Learnskin. And she's got a wealth of experience, not only as a dermatologist, but in clinical trials too. She was the director of dermatology clinical research at UC Irvine when she was on faculty there for 5 years. And she runs a very robust clinical trials practice now, in addition to her clinical duties. And so she knows psoriasis inside out, knows every little nuance of it because she's probably studied it. So Jennifer, we're really excited to have you on the podcast.
Yes, absolutely.
Thanks so much, Raja and Hadar.
So the topic for today is something that probably needs to be talked about more. We definitely see it all the time, and it's genital psoriasis. So Jennifer, could you talk us through a little bit about genital psoriasis and why it's so important in your opinion?
Absolutely. So, my first preview on genital psoriasis was several years ago when I was asked to, in fact, participate in a study looking specifically at treating genital psoriasis with a biologic. And at the time, I wasn't really convinced that it was actually a prevalent issue until I started actually asking my patients routinely about it. At first, I thought, is it really that prevalent? Because not many patients were telling me that it was an issue. And in fact, the more I started to learn about it, the more I was surprised and impressed by what I learned. So in fact, many surveys have showed that patients with psoriasis, up to 2/3, in fact, have had a current or previous history of genital involvement. And when I saw that number, I thought I was actually a little surprised that it was that high. But when I started asking my patients about it, it seemed like suddenly everyone has genital psoriasis. And what I learned was that my patients were just kind of embarrassed and scared to kind of ask me about it. But when I broached the subject, they were like, well, actually, in fact, I didn't know that it could affect that area. So there's a lot of patients out there who have it, but who are interested in learning more about it and didn't realize that psoriasis could in fact involve that area of the body.
On that note, Jennifer, do you mind just taking us through where do people commonly think psoriasis affects the body? And then what are the sites that probably people are not thinking about when it comes to psoriasis? Obviously, the genitals being one of them, but just as an overview for all those that are listening who might not be, or maybe they're familiar with psoriasis, but might not be familiar with all the nuances.
Yeah, great question. I think going back to the basics, we all think of psoriasis being most commonly affecting places like the elbows and knees. Perhaps it's because it's the most visible area. Other areas include anywhere on the chest, back, your legs. Other really tough to treat areas are the scalp. So as well as any of the fold areas of the body. So like in your underarms or underneath the breasts or in your groin area. And then hands and feet. So those areas can be really challenging because imagine you do everything with your hands and then you walk with your feet. When you get psoriasis on those areas, it can be really thick, crack, painful, and really limiting your ability to walk and then absolutely, limiting your ability to use your hands. So in fact, psoriasis can affect anywhere of the body. And the area I haven't mentioned yet is actually your face. So studies have shown that patients who it's not common to have it on your face, but when it does affect your face, it tends to correlate with really bad scalp psoriasis.
And Jennifer, I wanted to go back on the idea of bringing up the topic of genital psoriasis. Maybe you can guide us about how you approach this with your patients and how we can bring up this sometimes sensitive issue. Because I know that I have patients who I've known for a while now and they don't bring it up, and it's tough to get it out of them. And some patients maybe never tell me and I don't know. Could you give us some tips on how you approach that?
So great question, because for me, it was a little bit of trial and error because I was trying to find patients who had genital psoriasis. So I learned very quickly that one, patients were really shy about it. So I tried many different things initially, but I found what was most giving them some information to think about. So I would say when I met a patient or I was doing their physical exam, checking which areas were affected by psoriasis, most patients, when we do a full skin exam, usually don't take off everything completely. And I'll say, well, did you know that psoriasis can affect your private area or your genital area? Is there something in that area you'd like me to examine? So just kind of giving them a fact that psoriasis can affect that area and then giving them an opportunity. Sometimes some of my patients, even the ones that have known me for a long time, will say, well, in fact, I do have something there. And then they'll be honest. I don't know if I'm ready to show it to you today, or no way am I ever going to show you. and then I'll tell them, you know what? I'm not going to be able to give you the right treatment until I examine that area. So just making them feel comfortable, first giving them the information that it can affect that area, and then at some time point they'll be comfortable in showing it to me. But it is, most people coming to a dermatologist are not expecting that they're going to get like a GYN exam or
Right.
a urological exam.
Right. And I think part of it is what we're doing right here, because this podcast goes out to any listener, not just practitioners. And I think the idea here is to tell the wide world to know that psoriasis and other skin diseases certainly affect genital areas, and we can help a lot of times, but it's often neglected, and it's just human nature. It's totally fine to be shy about it, but at some point you may want to bring it up with your dermatologist because we have some solutions.
Yeah, and on that note, Hadar, I think maybe if you don't mind, Jennifer, can you take us through where exactly in the anatomy, when you talk about genital psoriasis, what are the areas that can be affected? Because I think it's really important that we let patients know that, this is an area that we regularly examine. So when you're talking about genitals, are we talking, of course, there's the penis, vagina, the anal area, but are there specific areas in those regions that get affected more often than not?
Absolutely. Speaking the same language is so important. So I have along those same lines, many patients will use many other terms or euphemisms for that area. So really getting down to using the anatomical terms is really important to kind of pinpoint kind of what area it's affecting. What's also unique about genital psoriasis is that it doesn't look like typical psoriasis, right? So what we're used to on other areas of skin is that it's a red, well-demarcated plaque with silvery scale. Well, lesions in the genital region aren't going to look like that because there's skin rubbing against skin. It's more moist, so you may not have that characteristic silvery scale. It's going to look well-demarcated red, but be more smooth. The skin in this area is also much thinner. So that's also the challenge when you're thinking about treatment as well. But going back to the anatomy, specifically the genital area for men is the penis, the scrotum area. And then for women, it's the vulva and the labia majora and the labia minora. Other areas that are related to the genital area that we also study, but is not classically considered genital specifically in that term, is the neighboring areas like the groin fold as well as the perianal area. So any of these areas can also be affected with psoriasis, but specifically is not genital.
Yeah, I think it's really nice to make sure we're all in the same terminology about this. Now, you talked about the challenges to treatment, and Hadar alluded to the challenges that might arise when thinking about treatment. Can you take us through what is your approach when you're thinking about treatment? Because obviously, okay, it's one thing to identify it, and now what do we do?
Great question. So actually, can we, right before we talk about treatment, one more step in diagnosis is before you get to treatment is really the
Sure.
differential. So
Oh, that's great.
yeah,
Yes.
so I kind of wanted to address that because, patients are coming from different places when they come to see you. Some patients come to you and they may already have a history of psoriasis, perhaps in their scalp or on the elbows and knees, and now they're getting a new spot on their genital area. So in those situations, if it's red, well demarcated, then most likely probably psoriasis. But there are other patients who their first psoriasis lesion is on a genital area, and those patients can be a lot more challenging. So your differential can include things like lichen planus, even syphilis, or even just lichen simplex chronicus, or even something as simple as a fixed drug eruption. So when you can't find any clues on the rest of the body, maybe looking in hard to, kind of hidden places like the scalp, behind the ears for other clues of psoriasis, even in the gluteal fold or the belly button area. In those situations, you may need to do a biopsy to kind of rule out everything else. Sometimes, and it depends on the patient, because doing biopsy in the skin genital area, it sounds really, really terrifying or painful. In some situations, I may just start off with a topical steroid because that may help a lot of the common conditions that we're thinking about and may not need a biopsy right away. But I tell the patient if it's not responding as I would expect, then definitely we're going to need to do a biopsy.
Yes, thank you for summarizing this. This is actually exactly my approach most of the times. Sometimes even skin cancers can look like that. And I think it's important to explain to the patients that it's not necessarily sexually transmitted diseases that we're thinking about, because there is that fear in a way. And many times I tell them, hey, it's sexually transmitted disease. You're lucky. It's not a chronic disease. We can treat this. So it's in a way, it's a good thing to consider the entire differential and then reassure the patients that there's things can be done if it's not psoriasis.
Absolutely. Yeah. I think the number one question my patients come with is, I've already done all the STD testing. Are you sure it's not an STD?
I mean, I guess there are a few chronic ones, but yes, by and large, it's good to go through the differential because overwhelmingly, many of them will come to a dermatologist with nystatin cream on board, typically.
Absolutely. Yeah. Yeah.
Yes.
Thinking that it's yeast. So it's really good to differentiate that as well. Well, do you mind taking us through treatment then, Jennifer?
Yeah, absolutely. So like I said, once you have your diagnosis or you have smaller differential in mind, really topical therapy is a good place to start, especially for mild disease. So most commonly we start with topical steroids. You may even start with topical calcineurin inhibitors like Elidel or Protopic, or even vitamin D analogs like Dovanex. Often, I start with a topical steroid, and I may, depending on how severe, inflamed, or thick the lesions are, I'll determine my steroid strength. The challenge with topical steroids is, our concern for side effects, including atrophy and striae, especially in this area where the skin is much thinner, and we know that the absorption is much higher because of the occlusion as well. So multiple components. It's also a really sensitive area, right? So many patients with genital psoriasis get erosions or even tears in the skin. So, whatever topical you apply may even cause irritation to the area. So it's a little bit of trial and error, but often we start with the topicals. When I do stronger topical steroids or start with something more gentle, it's usually for short periods of time, and I'll check in with the patient more frequently. So I'll say, you can use this up to a week, or 2 weeks, but I want to see back. I want to make sure it's responding. Once I see it responding, then we're going to talk about maintenance. Often I'll move to a topical calcineurin inhibitor like Protopic. That's my personal favorite, and see if that can be helpful as maintenance. But the challenge with Protopic is that often it can cause burning on initial use, right? So then the patient has to get past that stage, especially for an area like the genital area where it's more painful already, and then you're adding something that can possibly worsen it initially.
And maybe something to keep in mind, because I have the same experience you do with both of the calcineurin inhibitors when I have them use it, or even crisaborole when I try to put that on topically, it burns, is that in men who are uncircumcised, it's even more sensitive if they have that area involved.
Absolutely, absolutely. So that's why, topicals are really reserved for really mild cases. And even, just today I saw, ironically, several patients for follow-up and for genital psoriasis, and really going through and educating them on how often they can use their topical steroid and how frequently, because they don't realize that every patient can respond differently. And, I've definitely seen striae in this area, and it really bums me out when I see it, because I feel like it's something that's totally preventable.
So perhaps moving from the focal event of psoriasis in the genitals, what I often see is genital psoriasis being part of a larger picture. And perhaps you can take us about the approach. And first, I want to ask is, do you find that this is an area that's more resistant to therapy when you put someone on systemic therapy for their overall general psoriasis?
Not necessarily. So, yeah, so there's lots of patients who may have mainly genital psoriasis, or there's patients who have generalized plaque psoriasis, and then also have genital involvement. So in patients who have more extensive disease, or in patients who have bad genital psoriasis, they are definitely candidates for systemic therapy. So, a big message from the American Academy of Dermatology is that there is definitely a profound impact on quality of life. So, in fact, some studies that genital disease alone can have a greater impact than typical plaque psoriasis. So, we classically think about, someone who has a body surface area of 10%, meeting the definition of moderate to severe, who would qualify for systemic therapy or biologic therapy. But really, the presence of genital disease alone that doesn't respond to topicals can be considered as moderate to severe disease because of the impact on quality of life.
Yeah, there's no question. I mean, genital involvement in almost every disease has such a profound impact, but in psoriasis, gosh, I mean, and not only the genitals, but if it affects the perianal area, then even like basic functions like defecation becomes really painful. Then on top of that, I feel like psoriasis sometimes can strip people of every aspect of what makes them feel good about themselves if we don't treat them adequately. Wouldn't you say, Jennifer? I mean, it's and not only the outside, it affects the inside too, with the joints and the cardiovascular risk. So really is a disease you got to be aggressive with.
Absolutely. And the one component we haven't even touched upon is really the impact on their sexual life. So intimacy, right? And so in fact, that is something that hasn't been researched as well or talked about, is the patients and as well as their partner's impact on their sexual life. And so I think that's really a big component of why when patients are asked about how it affects their quality of life, that we see that the numbers are much higher than we realize. So, and we forget that to ask them about how it affects their frequency of sex and intimacy as well.
Yes, absolutely. And we see this a lot in a disease that also affects the genital area, like hidradenitis suppurativa. And there's some early data there about sexual, I would call it almost like sexual disability.
Yeah.
And we don't
Yeah.
touch that area in our patient visits. So I think it's very important to bring that up and make sure that our patients understand that this is definitely part of the therapy, and certainly a reason to be more aggressive if needed to achieve the results that we're looking for. And one of the things to keep in mind is that many times psoriasis begins at a younger age. So sometimes we see skin disease and we treat people who are, let's say, over 50 years old, and so they have already their kind of life in place and they have a long-term relationship with a partner who knows them. But when it starts at a young age, when people are professionals, it affects their job if they can't sit at work, or it affects their sexual life and intimate relationships. For sure, it's something that we should consider. And again, sort of a public service announcement to let our patients know that it's okay to talk about this and bring it up and say, this is important to me. And even though by surface area it may not look like a big deal, it is a big deal on my life.
Yeah. And you asked a great question is, would smaller surface areas still qualify a patient for systemic treatment? So, and what types of treatments respond, excuse me, better to, are there better treatments for genital psoriasis specifically, or can it be more challenging? So it can definitely be a lot more challenging. And the hard thing is that there's actually very limited published data on genital psoriasis treatment. And so we talked about the challenges already with topical treatments, right? So topicals can cause irritation or stinging. You can't use them for too long sometimes, depending on the strength of the topical steroid. And with systemics, because there's a lack of studies or published trials on it, it can sometimes be hard for the dermatologist or practitioner to decide on, what to do next. And in fact, about 2 years ago was the first ever systemic treatment that was studied rigorously in a phase 3 trial specifically for the treatment of genital psoriasis. And in fact, it was a biologic called Taltz. And they looked at 2 groups of patients with genital psoriasis, those who had primarily genital disease, and then they had to have at least just one plaque of psoriasis elsewhere on the body. And then another group of patients who had primarily plaque psoriasis, which met the body surface area of 10% on the rest of the body, as well as genital lesions specifically. So studied both of these patients. These patients had treatment with Taltz, and they saw that after 12 weeks, over 70% of these patients had clear, almost clear skin in the genital area. But prior to this, really, almost very few or no dedicated trials looking at systemic treatment for genital psoriasis.
Yeah, it's about time that people are looking at this as something that should be treated. So it's good to hear about that. And Jennifer, you also have served as the chair for the psoriasis CME program that was released on Learnskin. Can you talk a little bit about that? Because I believe one of the sessions is, or the learning activities is about genital psoriasis.
That's right. So it was one of my close colleagues. I think it was Jennifer Cather, amazing dermatologist out of Texas, and very, very in touch with her patients. For her, it was easy for her to ask her patients about genital disease. She would tell her patients, because she's from Texas, that, that even though, most things in Texas are big, but, genital disease only affects a small surface area, and it still means that it's a big deal. So she talks about her experience with her patients, and also the impact of genital disease on quality of life, as well as treatment options. Besides genital disease, it's a great opportunity to learn more about other niche areas of psoriasis, including women in psoriasis, as well as the latest on biologic treatments, other traditional systemic treatments, as well as learning about all the different comorbidities of psoriasis. We really see psoriasis as truly a systemic disease that has inflammation that extends from the skin that can affect the joints and other other organs as well. So a great opportunity. It's free, right, Raja? It's still free. And so to earn your CME credits.
That's right. Yeah, because we had generous supporters for the program. So it is available on learnskin.com.
Yeah, and it's a wonderful series, and well done on putting together such a cadre of speakers that are very eloquent and cover the topics pretty well. I got to say, I enjoyed it very
Kudos to
much.
you, Jennifer. Nice job on that.
Thank you. It's definitely teamwork. I thank all of my experts and sharing their knowledge with all of us.
So maybe to summarize about the idea of genital psoriasis, could you give us a few take-home message that people can think about, both practitioners and patients who may be listening?
So I think, one of the most important things is that genital disease is actually common, and then definitely ask your doctor about it. I think another common question I get is, can I still have sex? Absolutely. So I tell patients, you're just going to need lots of lubricant, and you can still definitely have sex. But my goal is to find a treatment so that we can heal those lesions on the genital area, and it is possible. Something else to keep in mind is that really not just the sexual dysfunction we talked about, is really the itch too. Psoriasis, sometimes we don't think of classically being really itchy, but in certain areas of the body, like the scalp as well as the genital, it can be really, really not just painful, but very itchy. So, and I think ultimately is be open-minded and don't be afraid to ask your patients, or don't be afraid to ask your doctor about psoriasis in sensitive areas like your private area.
So Jennifer, I really want to thank you for educating us about genital psoriasis, and we're looking forward to more series from you about psoriasis and more speakers that you can bring together to advance our knowledge on this very important disease. Thank you very much.
It's been a pleasure.
Yeah, great talking to you, Jennifer.
Thank you for tuning into the Learnskin podcast with Dr. Raja and Dr. Hadar. We hope you have enjoyed this discussion with Dr. Jennifer Soung, Program Chair for the Learnskin Psoriasis series. Dr. Soung has served as Clinical Research Investigator by Eli Lilly. Learnskin offers a variety of CME programs at learnskin.com. Learn more about psoriasis in the 14 series program and earn 10.5 continuing education credits. Topics include topical treatments, oral therapies, comorbidities, pediatrics, safety, biosimilars for psoriasis, and more. Now available at learnskin.com/series/psoriasis-series.